Hey everyone, thanks for tuning in. Steven here with Team Euphoric, and today I'm going to be taking you through 20 common neurological conditions along with targeted exercises you can perform to speed up your recovery and eliminate your pain. Now let's get started. The fourth neurological condition is CAUDA equina syndrome, which is when there is severe lumbar nerve root compression between the L1 and S5 nerve roots, causing saddle anesthesia, bowel or bladder dysfunction, and leg weakness. To treat this condition, the Eldoa exercises and nerve gliding exercises are terrific when prescribed correctly. Since the L4, L5, and L5S1 vertebra are the most commonly compressed regions in the lumbar spine, you can try the L4, L5 Eldoa, the L5S1 Eldoa, and the supine and seated sciatic nerve gliding exercises. First, let's go over the L4, L5 Eldoa. For the exercise, we want to go ahead, we're sitting on the ischial tuberosities or our sit bones where the hamstring's attached to, and we want to go ahead and we are going to start by placing the heels at the level of the ischial tuberosities, roughly 1 fist width apart. From here, we want to go ahead and flex the knees to 90 degrees. We want to go into plantar flexion by pointing the toes toward our head, eversion by pointing the soles of our feet away from each other, and then we're going to drive our knees down to the ground by going into abduction and lateral rotation. At the pelvis, we want the coccyx pressing down into the floor as with the knees. We want to maintain retroversion of the pelvis or a posterior pelvic tilt. We have a flat lumbar spine, a flat thoracic spine, retropulsion of the cervical spine by tucking the chin in. The crown of our head is pushing up to the sky with the eyes looking down at the floor to put the dura mater under tension. With the arms, we want to go into maximum extension of elbows and wrists, maximum external rotation of the shoulders, and then flexion of the shoulders to the coronal plane, and we're pressing the palms up toward the sky. So just to recap, heels, level of the ischial tuberosities, fist width apart, flex the knees to 90, go into dorsiflexion, eversion, lateral rotation and abduction of the femurs. We have retroversion of the pelvis, coccyx is pressing down, flat lumbar, flat thoracic, retropulsion of the cervical spine, crown of the head up, eyes down to put the dura mater under tension, maximum extension of elbow and wrist with maximum lateral rotation of shoulders, flex to the coronal plane, and press up toward the sky. We're going to maintain all of those components for 1 minute, and then we are going to slowly come on out of the posture. Next, let's go over the L5S1 Eldoa. What you would want to do is you would perform this exercise against a wall. Right now, I have the massage table set up, so I'm going to imagine that the massage table is my wall. But when you perform this at home, or if you're prescribing it to a patient, you would want to do it against an actual wall. What you would want to do is you're going to get down onto your side to start, and you want to get your butt nice and close to the wall. Once your butt's nice and close to the wall, what you would want to do is you are going to turn your body up toward the sky. From here, you want to try and glide your heels up toward the wall with your heels at the level of your ischial tuberosities, roughly 1 fist width apart. You want maximum extension of the knees, and you want to try and get your calves away from the wall as much, or your heels away from the wall as much as possible. You want to go into pseudo inversion, so we're going to go into a combination of dorsiflexion by pointing the toes toward our head, inversion by pointing the soles of our feet inward, and we want to go into medial rotation just enough that our toes aren't touching. We should be able to slide a piece of paper in between there. From here, we're gliding up the wall with our heels and pressing down into the floor with the sacrum. And then moving down, we want to press the coccyx into the wall. We want retroversion of the pelvis or a posterior pelvic tilt. We want to maintain a flat lumbar spine by pressing the spine down into the ground. Try to relax your abdominals. Flat thoracic spine, retropulsion of the cervical spine by tucking your chin in. The crown of your head is pushing away from the wall with the coccyx pressing into the wall, and your eyes are looking down between the thighs to put the dura mater under tension. With your arms, we want maximum extension of elbows and wrists, maximum external rotation. Bring the arms into flexion to the level of the coronal plane, and we want to just raise our head up off the ground, just enough that you can slide your fingertips underneath. And the palms are pressing away. So just to recap, we have maximum extension of the knees. The heels are 1 fist width apart or the level of the ischial tuberosities. We have dorsiflexion, inversion, medial rotation, retroversion of the pelvis. Heels are going up, sacrum is going down. Coccyx is going into the wall. We got retroversion of the pelvis, flat lumbar, flat thoracic, retropulsion of the cervical spine. Crown of the head is pushing away. Eyes are looking down. one fingertip away from the wall or away from the floor, maximum extension of elbows and wrists, maximum external rotation of shoulders. Flex the arms to the level of the coronal plane, press the palms away, and we're going to hold that for 1 minute. After 1 minute, we're just going to slowly come on out of the posture, turn over onto our side, and next, let's go over the supine sciatic nerve gliding exercise. And I'm going to show you a bunch of different progressions that we can incorporate for this supine variation. What we would want to do is first, we're going to just go ahead, and the first thing that we could do is on the affected limb, we would just go into hip flexion. And while we go into hip flexion, we want to just have the knee and ankle completely relaxed. Do 3 to 5 repetitions. And then we want to check in with ourselves and ask ourselves, have my symptoms either gotten better, worse, or have they stayed the same? If you've noticed that your symptoms have either gotten worse or they've stayed the same, we would immediately stop with the exercise. There's no need to continue. We don't want to exacerbate your symptoms. However, if you've noticed that there's been an immediate improvement, we would go ahead and perform an additional 20 repetitions of hip flexion. If you didn't really notice any issues with regard to hip flexion, what we could do is just go ahead, cup our hands underneath the posterior thigh or our hamstrings, and then we are going to add a component of knee extension. We would do 3 to 5 repetitions. And once again, we're going to check in with ourselves and ask ourselves, have my symptoms either gotten better, gotten worse, or have they stayed the same? If they have gotten worse or stayed the same, we would immediately stop with the exercise because there's no need to continue. We don't want to exacerbate your symptoms. However, if your symptoms have gotten better, then we would go ahead and perform 20 additional repetitions. Let's say you've done the hip flexion, you've done the knee extension, you still haven't noticed any reproduction of your symptoms. What we could do is point your toes toward your head and do dorsiflexion for 3 to 5 repetitions. And then check in with ourselves once again and ask ourselves, have my symptoms either gotten better, worse, or have they stayed the same? If you've noticed that they've gotten worse or stayed the same, we would immediately stop with the exercise. There's no need to continue. We don't want to exacerbate your symptoms. However, if they have gotten better, we're going to go ahead, maintain that hip flexion, knee extension, and do 20 repetitions of dorsiflexion. If you've done the hip flexion, you've done the knee extension, you've done the dorsiflexion, you still haven't noticed the reproduction of your symptoms, we're going to add one more component to put maximum stretch on the maximum tension on the nerve, and that is going to be cervical flexion. We want maximum cervical flexion, 3 to 5 repetitions, touch that chin to the chest. And after 3 to 5 repetitions, we're going to check in with ourselves and we're going to ask ourselves, have my symptoms gotten better, worse, or have they stayed the same? If you've noticed that your symptoms have either gotten worse or stayed the same, we would immediately stop. There's no need to continue. However, if you have noticed an immediate improvement in your symptoms, what we could do is maintain that hip flexion, knee extension, dorsiflexion, and do 20 repetitions of cervical flexion. We could also start with the cervical flexion. So if you wanted to, we could literally do the exact same thing that we did. So we would start with cervical flexion. The first thing that we could do is just the hip flexion. Check, see if that's okay. If that's okay, we could add in the knee extension. If that's okay, then we could do it. That would be if we want to work from proximal all the way to distal. The other thing that we could do, if we wanted to make it more of a gliding variation, then what we could do is work in opposites. So we would build tension at one end while releasing tension at the other. A few different ways that we could do that. Let's say we wanted to work more intermediately and proximally. What we could do, when we go into hip flexion, we are building tension at the hip area. So if we want to build tension at the hip and get more of a gliding motion, we could go into cervical extension to release tension. And then when we go into hip extension, we would go into cervical flexion. When we go into hip extension, we're releasing tension at the hip, building tension at the cervical spine. So we would work in opposites. So we're going hip flexion, cervical extension, hip extension, cervical flexion. The other thing that we could do is we could maintain that hip flexion, and we could do the same thing. As we straighten out the knee, we look up. As we bend the knee, we look down. So it's up, up, down, down, up, down, down. We could do the same thing with the ankle. So we could have that knee in full extension. And then as we point the toes toward our head looks up. As we point our toes toward the sky, our head looks down. So up, up, down, down, up, down, down. We could also do all of that at once. So we could get a lot more of a gliding technique. And what we would do for that is when we could go into hip flexion, knee flexion, dorsiflexion, and then go into hip extension, knee extension, plantar flexion. So we're going up, down, point the toes away, toward your head, away. We could do all of that while incorporating the cervical extension. So when we go into hip flexion, dorsiflexion, we go ahead and look up. When we go into hip extension, plantar flexion, we look down. Up, down, up, down. There's a lot of different ways in which we can play with this exercise. Lastly, let's go over the seated slump test nerve gliding exercise. I'm going to just take you through all of the steps first before we start isolating the different movements. The first thing that we want to do is you want to go ahead and get into a slunched or slumped position. So we're going to just go ahead, flex forward, and we want to do 3 to 5 repetitions of that. And then we're going to check in with ourselves and ask ourselves, have my symptoms either gotten better, worse, or stayed the same? If you have noticed that your symptoms have either gotten worse or stayed the same, we would immediately stop with the exercise. There is no need to continue. We don't want to exacerbate your symptoms. However, if you have noticed an immediate improvement of your symptoms, we would go ahead and perform 20 additional repetitions of flexing that thoracic and lumbar spine. Let's say you've done the slump, so you've done that flexion, and you still haven't noticed the reproduction of your symptoms. The next thing that we would do is go ahead and we would go and maximally flex the cervical spine by touching that chin toward the chest for 3 to 5 repetitions. And then we would check in with ourselves and ask ourselves, have my symptoms either gotten better, worse, or stayed the same? If you have noticed that your symptoms have either gotten worse or stayed the same, we would immediately stop with the exercise. There is no need to continue. We don't want to exacerbate your symptoms. However, if you have noticed an immediate improvement in your symptoms, we would go ahead and perform an additional 20 repetitions of cervical flexion while maintaining that slumped position. Let's say if after you've done the slump, after you've done the cervical flexion, you still haven't noticed a reproduction of your symptoms, we could build tension on the nerve by going into full knee extension for 3 to 5 repetitions. And then we would go ahead and check in with ourselves. And once again, we want to ask ourselves, have my symptoms either gotten better, worse, or stayed the same? If you have noticed that your symptoms have either gotten worse or stayed the same, we would immediately stop with the exercise. There is no need to continue. We don't want to exacerbate your symptoms. However, if you have noticed an immediate improvement, we're going to maintain the slumped position, maintain the cervical flexion, and perform 20 additional repetitions of full knee extension. Let's say you've done the slump, done the cervical flexion, done the knee extension. You still haven't noticed a reproduction of your symptoms. One more thing that we could do to build tension on the nerve is go into dorsiflexion by pointing those toes toward your head for 3 to 5 repetitions. And once again, we want to ask ourselves, have my symptoms either gotten better, worse, or stayed the same? If you have noticed that your symptoms have either gotten worse or stayed the same, we would immediately stop with the exercise. There's no need to continue. We don't want to exacerbate your symptoms. However, if we have noticed that our symptoms have immediately improved, we would go ahead, maintain that slump, cervical flexion, and knee extension, and perform 20 additional repetitions of dorsiflexion. That is how we would perform the exercise if we wanted to isolate each of the different movements. If we wanted to do more of a gliding motion, we could segregate certain segments, and we could also do one gigantic exercise. If we wanted to segregate the proximal attachment, so the higher fibers, the way that we would do that is we could combine the slump with extension of the cervical spine, and then we are going to go into extension of the spine and flexion of the cervical spine. So what's going to happen is, as we go into cervical flexion, if we maintain that extension, we're putting tension at the proximal attachment, and then at the intermediate section, we're releasing some of the tension. And then when we go into the slump position and go into cervical extension, we're placing more tension more intermediately, and we're releasing tension superiorly or proximally. So we would go ahead and do that. We would go up, flex. So we do flexion, extension, extension, flexion. And same thing, after 3 repetitions, you would check in with yourself. If everything was good, you would perform an additional 20. Another option is we could go ahead and we could do the slump knee extension, and then we could go ahead and work all the way proximal to all the way distal. So as we go into dorsiflexion, we look up to the sky. As we go into plantar flexion, we look down to the floor. And we would go ahead and do the same thing. Look up, look down. Point up, point down. When we point the toes down, we release tension at the distal end. When we look down, we place tension at the proximal attachment. When we look up and point the toes up, We're releasing tension up top. We're building tension at the bottom. That's another way that we could do it. Another thing that we could do is we could go ahead and work just more distally. So that was more globally where we were working proximal to distal. If we want, we could go knee extension and point the toes, and then dorsiflexion as we come into knee flexion. So as we go into knee extension, we're placing tension a little bit more inferiorly and releasing tension at the most inferior aspect. And then as we go into dorsiflexion with the knee flexion, we're building up the tension most distally and releasing some of the tension a little bit more inferiorly, but superior to the part that we were working at. So we straighten out the knee, point the toes, curl the toes up as we flex the knee. And those are a few of the different ways in which we can do a little bit of nerve gliding using the slump test as an actual treatment exercise. The fifth neurological condition is carpal tunnel syndrome. That was just a tiny taste of what can be found in my members only section. If you enjoyed it, become a member for only $5 a month to get access to hundreds of member only videos.